Hello again, this is Earl Silverman, Editor-in-Chief of the Journal of Rheumatology. Welcome you to the May 2023 edition of the Journal of Rheumatology, interviewing a paper of particular interest. Today I will be interviewing Dr. Barber. The article I picked for more in-depth review is entitled Investigating Associations Between Access to Rheumatology Care, Treatment, Continuous Care, and Healthcare Utilization and Costs Among Older Individuals with Rheumatoid Arthritis. And it's by Dr. Claire Barber and colleagues. And today I'm very pleased to be speaking with Dr. Barber, the first author of the paper. And Claire, I want to thank you for taking the time to speak to me and our listeners. So with that, shall we begin? Sound good? Okay. Great. So could you just briefly describe the background and the rationale for performing your study? But before you do that, I just want to say I like the use of the word older. Being somebody older, I like that use. So.
Thanks so much. Such a privilege to be here chatting with you about this paper today. So as we all know, rheumatoid arthritis is the most prevalent autoimmune inflammatory arthritis, and it incurs a large personal and also societal burden. And we previously worked nationally over the last decade or so to define a set of system-level performance measures for rheumatoid arthritis. So these are performance measures to evaluate the care quality that is provided at a health system level to individuals with rheumatoid arthritis. And from prior work, we've demonstrated some gaps in care provincially in several Canadian provinces, including Alberta, Ontario, and British Columbia. But what's been less clear is whether improved quality of care or conversely, these gaps as measured by the performance measures result in changes to patient outcomes or healthcare costs. And so in this study, we were really interested in understanding the impact of measured performance on healthcare costs.
Good. Even I can understand that, so that's good. And can you review who you studied and what were the performance measures you studied?
Yes, thanks. So we studied a retrospective population-based cohort of older individuals aged 66 and older who had a diagnosis of rheumatoid arthritis in Ontario and had been seen by rheumatologists at least once as part of our case definition. And we used a validated case definition, of course, and working with Jess Widdifield and experts in Ontario around this. And one thing to note is why we selected looking at this in older individuals. Well, first of all, they do incur higher healthcare costs, approximately 45% of healthcare costs at a population level. So certainly a very important population to look at, but also some of the performance measures addressed treatment with disease-modifying anti-rheumatic drugs. And in Ontario, the Ontario Drug Benefit Program covers most of the costs of medications in the province for those aged 65 and older. And so, whereas we had incomplete data on younger individuals. And so to allow for kind of the year for individuals to enroll in this program, we used a cohort age 66 and older. And then we linked a number of health administrative data sets for analysis of the performance measures to determine their impact on healthcare utilization and costs. And so the specific performance measures we looked at, there were 4 of them. So the first is really a measure of access to rheumatology. So this is not a wait time. It's important to make that distinction. It's basically kind of getting a measure of almost who is not getting seen. So we looked at defining this measure based on individuals who had seen a rheumatologist within 365 days of the first RA code. And that could have been made by a primary care physician or somebody else. The second measure was having persistent rheumatology care follow-up, and this was defined by having an annual rheumatologist visit. The third was having at least an annual dispensation of a disease-modifying anti-rheumatic drug, so from the pharmacy through pharmacy data. And then the last is looking at timely receipt of treatment. So this is within 90 days prior or within 14 days after the first visit.
Okay, good, thank you. And the other thing, how did you measure costs?
So we determined direct healthcare costs from a health system payer perspective. So that's the who's paying for the costs using a validated person level costing algorithm. And so the costs are all expressed in 2019 Canadian dollars. And we evaluated costs for hospitalizations, emergency department visits, same-day surgeries, and these were calculated according to something called resource intensity weight methods. And this involves multiplying individual case resource intensity weights by the average provincial cost per weighted case. And this is determined by case mix group. And so we also looked at costs for things like prescription drugs, and they were calculated on an individual basis. And then we also had access to things like outpatient diagnostic or lab tests. And so these were also captured. We also had sort of a catch-all group that I'll just mention because it does come up in the results, where we had other costs, including non-physician claims, things for optometrists, I think, and physiotherapists, things like that. And this also included some complex continuing care costs, long-term care costs, home care, some cancer and dialysis clinics. So a bit of a kind of catch-all bag that was included in a separate category. And then we calculated annual healthcare utilization and mean annualized costs for the cohort and compared individuals who had or hadn't met, or where the performance measures had or hadn't been met.
Thank you. And so what did you find?
So we had over 13,000 individuals in the cohort, and the mean age was around 74, as we would expect, and 63% were female. Looking just at the performance measures and who met what, just to get a snapshot of that. So the majority met our access measure, and that's partly because of the way we define the cohort. So 94% had seen a rheumatologist within a year. 63% had at least one annual rheumatologist visit for the period of follow-up. 57% had an annual DMARD dispensation, and 60% had timely DMARD initiation. If we looked across all the performance measures, they were met for approximately a third of the cohort. Then when we looked at costs, sort of the annual mean cost for the cohort did seem to increase over our 5 years of follow-up, with mean total direct costs for patients by 5 years, or just under about $14,000 in the 2019 Canadian dollars. And 22% of these costs were due to medications, 21% due to inpatient costs. And then that other group that I talked about, those other kind of catch-all group of costs, were substantial. So they were about 30% of the costs. Then we examined whether meeting the performance measures in the first 4 years following diagnosis was associated with total costs in the 5th year following diagnosis. To do this, we looked at multivariable linear regression models and to estimate the log costs. And these results were determined and reported in terms of the mean % relative cost reduction or increase. And so we looked at several covariates for this analysis in our fully adjusted models, including age, sex, income quintile, diagnosis period, aggregated diagnosis group, the presence of a number of comorbidities, and you can read the paper to get a sense of what we looked at in health region. And in our fully adjusted models, access to rheumatology care and timely treatment were independently associated with lower costs, which is sort of the main take-home message. Although perhaps unsurprisingly, yearly rheumatology care and DMARD treatment were associated with higher costs, predominantly due to specialist visits and treatment costs. And so when we look at the kind of that percent, difference in costs, so costs for those not meeting access to rheumatology care were about 20% higher, and costs for those not meeting the timely treatment were about 6% higher. And the main driver for cost savings for those who had all the four performance measures met were kind of lower other categories, so including the complex continuing care, home care, long-term care. But we also did see fewer hospitalization emergency visits, leading to also to lower costs.
It's interesting that, remember what you just said, it was non-access to rheumatology care. It was important. Makes you feel good, doesn't it? So, all studies have limitations, and could you just please go over some important ones in particular, and pros and cons of databases, administrative databases, which always come up.
Yeah, no, thanks. Always important to discuss. So I think that the first I'll just describe is the performance measures themselves. And so really they're a minimum standard of care. As I said, it's not a wait time, it's looking at an access measure. We didn't have access to wait times because of, the limitations of administrative data. They're just, the referral data is not captured in the sources that we had. And so it's really possible that more granular measures may better show improvements in patient outcomes, leading to lower cost. So it may be that we need different measures, but these were the ones that we worked with. Our results also applied to individuals age 66 and older, and it's likely that the distribution of costs might be different among young individuals. And it may also be different than other healthcare systems where medications may or may not be covered, for example. And then, as you mentioned, there are many limitations to health administrative data, and one is that there's a potential for misclassification. And importantly in this study is that we didn't include individuals who never saw a rheumatologist. And so this could have impacted findings, as it's possible that group may have, different outcomes and different health system costs. There's a number of things that we would have liked to adjust for in terms of confounding things like disease activity. Again, they're not captured in an administrative data set. So there's certainly some things that could have impacted our findings. Thank you.
Thank you. Great. And so what are the implications then for the care? What do you believe the implications are? And what else do you think you or other people need to do?
So I'd say overall, our studies suggest that access to rheumatologists and early treatment does appear to be associated with lower total healthcare costs at 5 years. So we really need to be, prioritizing that and making sure that that message goes to government and others, and really prioritize strategies to help improve access to RA care. And then likely more granular measures may be needed, and or kind of further adjustment for confounders to investigate the potential cost savings of ongoing care and treatment. Although I'd like to highlight that sometimes we can't always save money with good care. Sometimes good care does cost money. So I think that that's also an important message that we need to consider.
Good, thank you. And where's it going to go? What are you going to do?
So thanks. So this is a study as part of a larger work funded by the Canadian Institutes for Health Research, or CIHR. And we're working presently with data in BC and Alberta to evaluate the impact of these measures on patient outcomes. So now just not looking at cost, but actually looking at outcomes, including the outcome of mortality and of total joint replacement. And so stay tuned. There'll be more interesting data, hopefully coming very shortly in that realm. And otherwise, I'd just like to take the opportunity, if there's a bit of time, just to thank my co-investigators, in particular the senior author, Dr. Jessica Widdifield, who unfortunately couldn't be here with us today, and the analyst, Ruth Croxford, for their tireless support of this work, and also acknowledging the support of funders like the CIHR. And I have some funding support from the Arthritis Society, which has been really instrumental in my career. So I'd like to thank them, and thank you for your time and support of this research.
Well, thanks. Perfect. Anything you want to add that we didn't discuss, or?
No, I think
you don't feel obliged.
Yeah, no, I think that probably covers what we wanted to chat today. I could talk all day about quality measurement, but you probably don't have all day. So
no, make another time. There we go. So thank you, Claire, for taking the time to review the important findings of this very interesting paper. And I want to thank our viewers, listeners, and suggest that they please read the complete manuscripts, because obviously we are at a high level and there's a lot of information that we just couldn't go over for time. And the paper, again, to remind you, investigating associations between access to rheumatology care treatment, continuous care, healthcare utilization, and costs among older individuals with rheumatoid arthritis, by Dr. Claire Barber and colleagues, and the paper is now available for your reading at the journal's website, www.jroom.org, and of course will appear in the May print edition of the journal. And I want to thank everybody for joining us, and hope you'll join us again next month, when I will speak to the author of another article of particular interest to the readership. I'd love to hear your comments, which can be sent to Twitter at jroom, or by email at manuscripts@jroom.com. Thanks.
Thank you.